morning, everyone. This session is on monitoring the patient on ventilator. I am Dr. Sritam. I am working as Associate Professor in the Department of Anesthesiology and Critical Care. So this module is very simple. And we know the number of cases are increasing who are infected with the novel coronavirus. So it is a tremendous burden on those who are involved in critical care of these patients. And so we want more and more healthcare workers to get trained to monitor these patients in ICU, so that whenever they are called upon to help the ICU team, they should be ready to come and help this when monitoring these patients in ICU, so that it will improve the care of these patients in ICU. So among those who are infected with this novel coronavirus, about 20% develop severe disease and they need hospitalization. Out of those, about 1/4 require admission to intensive care units, which accounts for about 5% of the total infected individuals. And the mortality rate among these is also very high. So this outcome of these patients who are admitted to ICU depends not only on the initial disease state, but also on the care provided. So monitoring these patients in ICU helps in optimizing the care, preventing the complications and improving the outcome of these patients. So in this session, we'll discuss about monitoring these patients' vital parameters, monitoring the ventilatory parameters, and the common alarms which we face in ICU and their troubleshooting. First, in this slide, you can see the display of a common cardiac monitor and the common parameters which we monitor in the ICU. So the first one is heart rate. Then comes the SpO2 or the oxygen saturation of hemoglobin, which is measured by the pulse oximeter. And the patients who have developed ARDS because of COVID, and in them, the target SpO2 we keep as 88 to 96%. And we also monitor the respiratory rate, the blood pressure, either in an invasive way or non-invasive way. Invasive blood pressure is required in those patients who require vasopressor support because of shock, and those patients who need repeated blood gas analysis. And non-invasive blood pressure is monitored in most of the cases. We also monitor the end-tidal carbon dioxide. The normal range is 30 to 40 millimeter of mercury, and it reflects the carbon dioxide level in the blood. We also monitor the oral or axillary temperature. Now coming to the monitoring the ventilation. First, in physical examination, we need to check the chest excursion. If the movement of chest is good and it is smooth and it is synchronous with the ventilator, it indicates that the patient is tolerating mechanical ventilation well and he is adequately sedated. And if the chest movement is shallow and it is rapid, it indicates that these lungs are stiff and they have decreased compliance. So the adequate tidal volume is not getting delivered. There can be leaks in the circuit, or there can be obstruction in the circuit. So the chest movement is not proper. If it is asymmetrical movement, then it may indicate that an endotracheal tube has entered into one side of the lungs, or there is development of pleural effusion on the other side of the lungs. Breath sounds, when you auscultate, we may see crepitations. Crepitations are nothing but either fluids or secretions inside the lungs. And if the breath sounds are absent, it may indicate that there is endobronchial intubation or pleural effusion development on one side. So I have a small sound clip of crepitation. We can play this. So this is not getting cleared. Okay, sorry. Now in the ventilator display panel, we may see the mode of ventilation. The mode of ventilation can be either controlled or spontaneous. Controlled mode means the patient's respiration is fully controlled by the ventilator. The basic control modes are the volume control mode and the pressure control mode. In the spontaneous ventilation, the patient initiates his breath, but it is supported by the ventilator. So the example is pressure support ventilation. In the patients who have developed major lung disease because of the COVID, we keep a tidal volume, low tidal volume. It is about 6 to 8 ml per kilo. If you give higher tidal volume, there will be more inflation and deflation of the alveoli that may cause more injury. And also it causes pass out of the carbon dioxide. So it decreases the PaCO2 in blood gas analysis. If you give lower tidal volume, it may cause ineffective ventilation. So it increases the carbon dioxide level in the blood. That will be detected as increased PaCO2 in the ABG. So by monitoring tidal volume, we can detect leaks, resistance, and improper ventilator settings, which cause improper delivery of tidal volume to the patients. Other monitors are the FiO2, that is the fraction of inspired oxygen. In the room air, we breathe about 21% of oxygen, but those patients who require mechanical ventilation, in them, we keep a higher oxygen concentration, 40-50%. And we titrate the oxygen concentration depending on the PaO2 from the ABG, SpO2 from the monitor, and PaO2 FiO2 ratio. If the ratio is improving, we have to come down on FiO2. Similarly, PEEP, or positive end expiratory pressure, it keeps the alveoli open even after expiration. So this PEEP is important because it keeps the alveoli open and it improves in continuous oxygenation. So we have to titrate the PEEP according to the oxygenation parameters as I told for FiO2. So the mode of ventilation and the tidal volume, they determine the carbon dioxide dynamics, and the FiO2 and PEEP, they are useful in improving the oxygenation. Now the airway pressures, we monitor two airway pressures, that is the peak peak and peak plat. The peak peak is nothing but the maximum inspiratory pressure at the end of inspiration, and peak plat is the pressure applied to the smaller airways and alveoli at the end of inspiration. In patients who have developed ARDS because of coronavirus infection, in those patients we keep a P plat target 30 centimeter of water, and it indicates the compliance of the lungs. That means if the lungs are stiff, the compliance is decreased and the P plat may increase. So it prevents barotrauma. And the P peak normally is about 25 centimeter of water. If it goes beyond 30 centimeter of water, it may indicate airway resistance. Inspiratory expiratory time, normally when you breathe, the expiratory time is double that of inspiratory time, and the ratio is 1:2. If you decrease the inspiratory time, it may affect the oxygenation. If you decrease the expiratory time, it may lead to ineffective ventilation. It may cause air trapping. Similarly, triggering is nothing but the ventilator sensing the patient's respiratory efforts. If the triggering is more, there can be more asynchronic. So you have to sedate the patient. Now coming to monitoring the blood gas parameters. In the ABG, along with the ventilatory parameters, you may see the pH, the bicarbonate, and other electrolytes, etc. But we'll simply discuss about the ventilatory parameters which you see in the ABG. So when you get one ABG and the pH is less than that of normal, that means the acidotic pH, and the PCO2 is high, that means the patient is retaining carbon dioxide because of ineffective ventilation. So you have to increase the ventilation by increasing the tidal volume and or by increasing the respiratory rate. Similarly, if the pH is alkalotic and the PCO2 is less, then you have to decrease the ventilation by decreasing tidal volume or respiratory rate. Similarly, you have to check the oxygenation parameter, that is the PaO2. If PaO2 is increasing, you have to come down on FiO2 and P. If it is decreasing, you have to increase the FiO2 and P. Other monitoring, these patients with ARDS, they have leaky capillaries inside their lungs. If you give enough amount of fluid, they may cause leakage into the alveoli and they may cause alveolar flooding. So you have to monitor the fluid status by strictly monitoring the input and the output. You have to monitor the depth of sedation. If the patient is not properly sedated, there will be fighting with the ventilator. If it is very deeply sedated, then there will be hemodynamic disturbances. So you have to monitor the sedation by sedation scores and by applying monitors like bispectral index. Also, you have to monitor the positioning, because every second only you have to change the position to prevent bed sore formation. So also in some patients may require prone positioning ventilation in severe cases. So during positioning, you have to look for dislodgement of the tubes, circuits, etc. Also, you have to monitor nutrition, infection control measures, and the long-term complications. Now, don't ignore the alarms which you commonly see in ICU. Different kind of alarms can come from the monitors, from the ventilators, and other equipments. These are automatic warning systems which indicate relevant deviation from the normal states. And these alarms can be acoustic, can be visual. You have to distinguish alarms which need immediate attention and those who can wait. If they are not attended, then it can be dangerous for the patient. Every equipment has some default alarms, and you have to set the alarms according to the patient's condition. The common alarms which you get from the monitors are the power backup alarms. Every time the monitor has to be attached to the continuous power backup. Low SpO2 means lower oxygenation. You have to improve the FiO2, you have to improve the PEEP, and other ventilator settings you have to measure. Bradycardia and tachycardia can happen. There are several causes of bradycardia and tachycardia. First, you have to check the placement of electrodes. Then, according to different causes which are coming to your mind, you have to intervene. Low blood pressure and high blood pressure. Low blood pressure can be because of leakage from the BP cuff. High blood pressure can be because of the loose fitting cuff or severing. After you examine the cuff position, etc., then you have to look at the cause. Low blood pressure can be because of hypovolemia or cardiac dysfunction. You may have to give vasopressors or fluid boluses. Hypertension, you have to treat stress, anxiety, pain, etc. If the patient is already on vasopressors, you have to come down on vasopressors. Tachypnea and bradypnea. Bradypnea can be because of deep sedation, the respiratory rate will be less. Tachypnea can be because of increased demand because of anxiety, fever, obstructed airway, etc. So you have to change the ventilatory settings and you may have to sedate the patient. Similarly, EtCO2, if it is low, that means the patient is hyperventilating and the carbon dioxide is getting washed out. If it is high, means patient is hyperventilating and the carbon dioxide is building up. So you have to change the ventilator settings. If it is absent, it may indicate the patient is disconnected from the ventilator. Abnormal temperature alarms when you get, you have to check the placement of the probe and you have to act accordingly. From the ventilators also, you can get the power backup alarms. There should be continuous power supply all the time, and there can be disconnection from the central pipeline supply. There can be less power, less supply in the pipelines, so it can show loss of pneumatic sources alarms. High air pressure alarms, as I discussed, there can be obstruction in the tubes like kinks, water in the circuit secretions, patient may be coughing, there can be bronchospasm. These may increase the airway pressure. You have to act accordingly. Low airway pressure alarms are usually because of disconnections or because of leaks from the different sites. In this picture, I have shown the different sites of possible leaks from the endotracheal tube, from the filter, from the circuits, etc. So you have to check these leaks and you have to repair. Then from another important alarm which comes from ventilator are the high and low minute ventilation alarms. Minute ventilation is nothing but the product of tidal volume and respiratory rate. Whenever either one or both of these increase, there will be increased minute ventilation and vice versa. So if the respiratory rate is less or the tidal volume is less, you have to check for the leaks, you have to relieve the obstruction, you have to sedate, you have to decrease the sedation because the patient is not breathing properly. If the tidal volume is increased, that means the patient is fighting or there is increased demand, you may have to sedate the patient. Similarly, if the respiratory rate is increased, you have to sedate the patient. So the take-home messages are appropriate monitoring techniques and correct interpretation of the data helps in understanding the disease. So always look for the dynamic changes in the variable over time. That is more important than static values, and multiple variables need to be integrated before you take a clinical decision. So monitoring helps in predicting and avoiding major complication. It improves the care by the healthcare personnel and it ensures the patient's safety. So before concluding, I want to ask you and discuss with you a few questions. The first question is, a patient who is diagnosed with COVID-19, he was put on volume controlled mode of ventilation. Next morning, his ABG shows pH, which is less than that of normal, 7.25, PaO2 about 105 millimeter mercury, and PCO2 is high, it is 55 millimeter mercury. What is the possible diagnosis and what is the next intervention? Respiratory alkalosis, increase the P, metabolic acidosis, increase the respiratory rate, respiratory acidosis, increase the respiratory rate, or respiratory acidosis, increase the FiO2. In this picture, you can see the PaCO2 is increasing, that means the patient is retaining carbon dioxide and the pH is less. So this is respiratory acidosis, so you have to increase the ventilation. So the answer is C, you have to increase the respiratory rate. This is the respiratory acidosis. Next question. A COVID patient who has developed ARDS was put on ventilator. During rounds, you saw that the patient has a respiratory rate of 40 per minute. He is sweating profusely and has a heart rate of 130 per minute. What should be the next intervention? Give muscle relaxant, decrease the set respiratory rate on ventilator, change the mode of ventilation, give midazolam 2 mg IV bolus. So in this clinical picture shows that patient is under stress. So patient is tachypneic, patient is tachycardic, and he is sweating. That means he is not tolerating the ventilator. So you have to give some sedation so that he will tolerate the ventilator and the endotracheal tube. So the answer is D. That means you have to give midazolam. Last question. A 62-year-old man who was diagnosed with COVID pneumonia was put on controlled mode of ventilation because of respiratory distress. Suddenly, the ventilator starts giving alarm and the display shows high peak pressure. So what is not a possible cause of such alarms? Kinking, thick secretions, soiled filter, and deflected cough. A deflected endotracheal cough means there is leak in the circuit. So definitely it cannot increase the airway pressure. So that is the answer, the deflected cough. Other causes, kinking, etc., secretions, soiled filter, etc., can increase the airway pressure. They will all increase the peak. I hope this session was useful. Thank you. Stay safe.